Millions more people in England could be prescribed daily cholesterol-lowering statin pills to cut their risk of a heart attack or stroke under new advice for the NHS. The National Institute for Health and Care Excellence says the cheap price of tablets and the possible health gains mean they should be considered more often. In England, high cholesterol leads to around 7% of all deaths. Well, I'm joined now by Dr. Aseem Malhotra. He is a consultant cardiologist and specialises in statins. Thank you for joining us this morning, Doctor.
Good morning.
In terms of what NICE are saying, your thoughts on that?
Yeah, so I have a great respect for NICE, but I think in this regard with statins, I think this guidance is misguided. And the reason I say that, Lagwessa, is something I've managed thousands of people with heart disease in my career, prescribed statins, particularly to high-risk people. And I just want to emphasize that people who've had a heart attack or high risk, that's where we see the greatest benefits of statins. But in this guidance, this basically applies to people who have a less than 10% risk. And if you have a less than 20% risk of having a heart attack or stroke in the next 10 years, one thing that we always tell patients when I prescribe statins or discuss it with them is that there is, first of all, no what we call mortality benefit. They're not going to live any longer over a 5-year period. And that the absolute benefits for them is about 1%, 1 in 100 in preventing a non-fatal heart attack or stroke. So that informed decision-making needs to be part of the process in discussion with patients and then help the patient make a decision themselves. In my own experience, Lagwessa, when most patients are told this information, they actually say, "Doc, to be honest, I don't really fancy those odds. Is there anything else I can do?" And of course, the big issue really that's ongoing, which has been going on for years in this country, is that we've not been addressing unhealthy lifestyles, or certainly being effective in curbing unhealthy lifestyles. We have this big problem with the obesity epidemic. And when you look at heart disease, my own research has found this, is that the best way to prevent heart disease and even manage people with heart disease, whether or not they choose to take a statin, is actually through lifestyle changes. So what does that mean in simple terms? It means cutting out ultra-processed foods, which is now half of the British diet. So foods that come in a packet that are full of unhealthy oils, carbohydrates, sugar, for example. Eating real food, basically. Moderate exercise, at least 30 minutes brisk walk a day. And also the other big sort of elephant in the room is stress reduction. Now, on top of that, Lagwessa, one of the reasons I think this has come into the news just now is obviously there's been a big concern recently around excess deaths. Now, the British Heart Foundation have said, certainly during the pandemic or since the pandemic, there's been 30,000 excess deaths specifically due to coronary artery disease. That's my area of expertise. And they're trying to figure out what's causing it. Chris Whitty recently suggested that it could be because people weren't prescribed statins or blood pressure pills. But Carl Hennigan, that unfortunately, I've got respect for Chris Whitty, but I think he's mistaken here, because analysis I've done, and even Carl Hennigan, the director of Centre of Evidence-Based Medicine, Oxford, suggests that statin pills prescription hasn't reduced since the pandemic. So it's unlikely to be a cause. But what is almost certainly, and if you allow me to say this, Lagwessa, what my own research has found, and this is something that is probably a likely contributory factor, is that the COVID mRNA vaccines do carry a cardiovascular risk. And I've actually called for the suspension of this pending an inquiry, because there's a lot of uncertainty at the moment about what's causing the excess deaths. Some of it will be ambulance delays. My own father, it was reported on BBC News in late 2021, I was the first to actually highlight the ambulance delays because my own father suffered a cardiac arrest at home and the ambulance took 30 minutes. And when his post-mortem came out, he had very severe coronary artery disease, which is unexplainable. I then published in a peer-reviewed journal. They accepted my findings that the likely cause of his death was 2 doses of the Pfizer mRNA vaccine he had 6 months earlier. So I think there's lots of...
I'm sorry, I just want to jump in on that point. So what you're saying in terms of the mRNA link to cardiovascular risk is that is it's been proven medically, has it? Scientifically?
Yes, Lagwessa. So in medicine, in any research that we do, it's very difficult to always be absolutely conclusive. So we go on likelihoods. And there are lots of data now. The highest quality data is what we call randomized controlled trial evidence. So there was a reanalysis in the journal Vaccine published recently, where they found that the original trials of Pfizer and Moderna with mRNA vaccines showed, and I just want to put this in absolute terms because we don't want to scare people unnecessarily, but the absolute risk of serious adverse events was at least 1 in 800.
Okay.
And a lot of those are cardiovascular. And then you were more likely in those trials to suffer a serious adverse event than to be hospitalized with COVID early on. And I think the vaccine has certainly helped people who are high risk, but now we should be reassured that Omicron and what's circulating is really no worse than the flu. And this is really time to pause the vaccine rollout and to really investigate this properly.
Okay, so I just want to clarify one point here, is using statins a cheaper, less resistant but short-sighted approach to lowering the risk?
I think you've summed it up perfectly. So it doesn't mean statins don't have a role, but the absolute benefits are very marginal in low-risk people.
Okay.
And actually, therefore, I would say to patients, this is the benefit, but if you cut out ultra-processed foods, if you engage in regular activity, and we need to help people do that as well. The problem is, as you know, a lot of the issues driving the obesity epidemic are related to the food environment. We have an oversupply of cheap ultra-processed foods that are very heavily marketed, and that drives a lot of behavior. And therefore, if we're really going to combat obesity, and I advised Matt Hancock on this when he was Secretary for Health, because I came out and highlighted the link between poor outcomes from COVID and obesity. And one of the things I told Matt Hancock, and it was reported in the newspaper, is that we need to introduce controls like we did with tobacco on these ultra-processed foods. So these are things like taxing ultra-processed foods, banning advertising of ultra-processed foods, and also a public health education campaign saying, if it comes out of a packet and it has 5 or more ingredients, don't eat it. And when you look at the cardiovascular risk, Wessa, what's really interesting in my own experience with patients is that very quickly, even within weeks, risk factors for heart disease through a process of helping reduce insulin resistance improve very, very quickly, purely from dietary changes. This isn't a long-term, it doesn't take a long sort of time to have this effect. It's very, very quick. And it's cheap. You're advising people to cut, and that's what we need to really be thinking about. That's what the focus should be, I think, in terms of what's going to be the biggest impacts on reducing heart disease.
Okay. Dr. Malhotra, thank you very much. Very in-depth explanation at the arguments for and against. Thank you for that. I've just got a little bit of information from NICE itself. So let me just read to you what their reaction has been. So the spokesman, Paul Crisp, for NICE, has said that what we're saying is that for people with a less than 10% risk over 10 years of a first heart attack or stroke, the decision to take a statin should be left to individual patients after an informed discussion of benefits and risks. The evidence is clear in our view that for people with a risk of 10% or less over 10 years, statins are an appropriate choice to reduce that risk. We are not advocating that statins are used alone, and very quickly the draft guidelines continue to say that it is only if lifestyle changes on their own are not sufficient and that other risk factors such as hypertension are also managed.